Okay, everybody. I'd just like to welcome members and guests of Thurrock's Health and Wellbeing meeting of the 4th of September 24th. Right. This is an in-person only meeting, so we can't accept people coming in online. As this is a committee of the council, the meeting is being recorded and streamed live on the council website. We will be using a kind of flag system. So you've got times for presentation. I believe most people have got about 20 minutes. So the flag system will be put up 2 minutes beforehand just to remind people that the 20 minutes has come to an end. In saying that, I will give a little bit of flexibility if it's quite an important item. Right, I just want to let people know that you are allocated seats. And they're allocated seats for the reasons of the live streaming. So we ask you not to move around because when the camera goes to your seat and you're not there, that'd be odd. So just ask you to stay in your particular seats. Right, I just want to remind people to use the microphone when they're speaking and just be mindful of turning it off and on when you're start and finish speaking. Okay? If I just go to apologies, I have apologies from Ian Wake, Councillor Hartstein, Claire Demmel, Sheila Murphy, Michelle Lucas, Jenny Burnett, and Jill Burns. Are there any other apologies?
Councillor Hooper, apologies from Alexandra McCann from the ICB.
Thank you very much.
Councillor Hooper, apologies from Alex Green from EPUT. I'm representing both Alex Green and Jill Burns from NELFT.
Thank you, Rita. Can I ask, do you all know each other? No? Should we just do a quick introduction then? So if I start off with you, Margaret.
Good afternoon. Margaret Allen, Deputy Alliance Director for Thurrock in Mid and South Essex ICB.
And I'm Jim Nicholson, and I'm the Independent Chair of the Thurrock Safeguarding Adult Board. Good afternoon.
Michael Deneen, and I am the Assistant Director for Community Safety Partnership, which is my role here.
Good afternoon, I'm Rita Takaria, Partnership Director across Health and Care, covering Thurrock Council, EPUT and NELFT and the Community Collaborative.
Hi, I'm Mark Tebbs, I'm the Chief Exec of Thurrock CVS.
Good afternoon, I'm Ali Birch, I'm Head of Connected Pathways at the ICB.
Good afternoon, my name's Andrew Graham and I'm the Adults Commissioner in the South End Essex and Thurrock Learning Disability and Autism Health Equalities team.
Good afternoon, I'm Andrea Clement, Assistant Director of Public Health. I'm here on behalf of Sharon Stoltz today.
Hello there, I'm Kim James from Health Watch Thurrock. Good afternoon.
Hello, John Kent, Leader of Thurrock Council.
And of course, I'm Mark Hooper, Chair of Health and Wellbeing Board, and I welcome you all today. I'd just like to say to members that we are currently scheduling the meetings 4 till 6, and I would like to review this after a couple of meetings to see if it's convenient to everyone to hold the meetings at this time. Right. Okay, so if I just move on to the items on the agenda. Now we've got the actions and the minutes or actions from February's board meeting, which I wasn't a member of. Do we need the minutes approved?
Just in principle, please, because there's some members that were members of the previous committee.
So were there members from February's meeting that were here in February? And have you read the minutes?
Thank you, I have, yes.
Would you say they're a correct record?
Yes, they're an accurate record.
You were here, Rita?
I'd second that.
Thank you, Rita. Right, there will be an action log will be maintained throughout the municipal year to just follow that we are doing what we say we're doing. So I think that will be sent out to people attending on a regular basis. Right. I haven't agreed to any urgent items for today's meeting. So I just want to ask members, are there any declarations of interest? I take that as a no. Right, if I move on to item 5 then please, which is the consequential amendments to the Health and Wellbeing Board Terms of Reference and Membership.
Yes, I'm presenting this item on behalf of Sharon Stoltz. So, as you're all obviously aware, the Health and Wellbeing Board is a statutory partnership board, and before we can amend the terms of reference or add members, for example, the Health and Wellbeing Board must be consulted. There's also in the terms of reference a commitment to review the terms of reference annually. So you've got the draft terms of reference circulated with the papers, and thus this item is to ask the Health and Wellbeing Board to agree the amendments recommended before they're then considered by the Council's monitoring officer. Just the main points to draw your attention to in terms of the terms of reference is in terms of the membership. So there has been minor amendments to reflect the change in personnel, and members of the board are asked to propose any new members they feel would be appropriate for consideration. In terms of the operation of the board, again, as we've already mentioned, there's the continued use of the flag system when there's 2 minutes remaining to speak. There's the continued use of the action decision log to provide an audit of decisions and approvals taken. And then also there will be a register of attendance maintained, and these all reflect the findings of the independent review of the board in 2022. The final point I just wanted to draw your attention to is that it's been proposed by the Thurrock Community Safety Partnership that Health and Wellbeing Board provides oversight of Thurrock's action plan in response to the Serious Violence Duty and Essex strategy. So that's for agreement by Health and Wellbeing Board today, and also agreement on, if it is agreed, how will this be overseen by the board. So for example, whether or not it will be an annual report to board or some other method. But that's the main things I wanted to draw your attention to today with the terms of reference.
Okay, thank you, Amanda. Do members feel that there should be other people that should be involved on this committee?
Thank you, Chair. Actually, Alexandra McCann is listed as being a member of this committee, and she won't be going forward. It will be me. So if you could replace Alex with me, that would be great.
Okay, any other people that you think would be useful to be part of this board? No? Okay, thank you. Right, so it's recommended that members agree the following consequential amendments to its terms of reference. So minor adjustments to the board membership to ensure that the TRO reflects changes in personnel. Members are asked to propose new members that they feel would be adequate, appropriate to the board, but we haven't had any. So are we agreeing to those recommendations? Yes. Right. Continuing to adapt a new operational approach as set out in the papers reflecting of the independent review of the board in 2022. Is that agreed? Right. It's been proposed that Thurrock Council Community Safety Partnership, that the board provides oversight to Thurrock Action Plan in response to serious violence duty and Essex strategy. This is to be agreed by members. Is this agreed? Right. Forms this year will be a record of attendance to the meeting. So that, yes? I take it that's agreed. Right, can I move on to agenda item 6, Better Care Fund. Right, so if I hand over to your good self.
Thank you, Chair. Welcome to, I'd like to introduce the Better Care Fund, a report covering 3 separate items. First, the submission of an update plan for 24-25, covering in the main the new arrangements we've put in place for discharge funding and ensuring we can avoid unnecessary admissions to hospital where possible and ensure people can leave hospital on a safe and timely basis. We're also presenting the year-end report for 23-24, last year's expenditure on the Better Care Fund, and a Q1 report for this year, 24-25, which primarily concerns our expenditure of the discharge fund element. Now, we're coming to you because we're required to present these to you. The Health and Wellbeing Board has oversight of the Better Care Fund. So this is something that we'll present to you from time to time. By way of background, I'd say that this is we've had a Better Care Fund for 10 years now. And during that time, it's developed somewhat. It started initially as a move to consolidate spend on social care for adults across health and social care, bringing the council and the NHS closer together. One of the requirements is that we are to pool our funds and to use those within the context of a Section 75 agreement, a legal agreement which sets out what our joint plans, our integrated plans for providing adult care are for the year in concern. So this is the 10th year we've done this. We last year brought to you a 2-year plan, as we were required, covering 23 to 25, and that's been approved. This presentation of the plan is an update for just the discharge fund element. So just a part of that we need to refresh to ensure that we're meeting the government's requirements and concerning hospital admissions and discharges. So the Better Care Fund started out by bringing together a number of council and health budgets and putting them into a pooled fund. In recent years, from 2022, we saw added to that an additional element which concerns discharge fund, that focus on admissions and admissions avoidance, and that's come to be a growing part of the fund that we have at the moment. The fund is overseen on a regular basis by an integrated commissioning executive comprising officers of the council and the NHS, meeting on a bi-monthly basis and receiving reports on performance on a monthly basis and looking at ways in which the delivery of services can be improved and the effectiveness and value for money also addressed. In regard to that, we commenced last year a review of the Better Care Fund, looking at the priorities that we had set, how they aligned to our strategy for adults, Better Care Together, Thurrock, and that's work that we're continuing to pursue. And over the next 6 months, we'll engage looking at how individual services are helping us ensure we deliver our strategy, Better Care Together, Thurrock, and play our part in the transformation of health and care and housing services for vulnerable adults. We're bringing this to you, as I say, because this is a requirement of the sign-off process, that we ask Health and Wellbeing to sign off the agreements. The services actually are in place and running, and during the course of the coming winter, we'll see some of the services required to deal with winter pressures very much gearing up, and that rather consumes the largest element of the discharge fund, which recently joined the Better Care Fund. I'd like to say that the approval of the Better Care Fund by NHS England, which we received last week, is very much a good news story. It's an endorsement of our focus on integration and transformation, and it will continue to be a key delivery mechanism for our strategy for adults. So returning to the recommendations, I'd like the board to consider signing off the three elements presented today: the updated template for expenditure on 24-25, the year-end report for last year, and the quarter one report for 24-25 as well. Thank you.
Thank you, Christopher. I wonder if you could, it's great news we've got this extra funding. It really is good news, and I'm hoping that we can start to share that with the wider community in the very near future. What does that really mean to Thurrock in terms of funding, and what's that kind of breakdown of funding look like?
The components of the Better Care Fund are a range of different elements. That includes the Disabled Facilities Grant, providing funding for adaptations and social care capital investment, and we've seen some small growth in the amount that we're allocated for Disabled Facilities Grants since last year, largely in line with inflation. There's also a minimum contribution which the NHS make to the fund. That's around 14 million this year, and that's also been uprated with inflation. And a small £5 million contribution, which is called the Improved Better Care Fund, and that's an additional element, again, focusing on transformation and integration. The Council itself, obviously, as part of its obligations to provide social care, invests significantly in home care and care home services, and those are also represented in the fund. Those come under the area of local authority contribution, additional contribution. It's around £31 million of expenditure, a growing area of expenditure because we are meeting far greater acuity of need. Then there's the discharge fund element, which, as I say, came in 2022. That's grown significantly this year from 1.7, 1.8 million in 23-24 to 2.6 million this year. So that's money that we've committed to hospital admission, avoiding hospital admissions and timely discharge. And that altogether comprises a fund of around 55 million, which is targeted to be used jointly with health to take forward our transformation programme.
Thank you. Are there any other questions? Right. And how much money do you think this approach is actually saving local authorities and health?
I can't put a financial value on that, but I do know that Thurrock is well regarded in ensuring that people don't go to hospital unnecessarily, and our performance in that regard shows well against national performance indicators. So we are ensuring that people aren't spending unnecessary time in hospital, and that we avoid delayed discharges from hospital. We're also very much investing in preventative services, so helping people before they get the need for adult social care or housing or health interventions. So in those regards, we're doing very well. One of the things that we want to draw out as part of the next stage of our Better Care Fund review is trying to put some indicators in place which can demonstrate the effect, the benefits that we're bringing local people through those investments. Not just, as I say, at the point of people going into hospital or needing to leave hospital, but preventing them, keeping them well at a much earlier phase in their care career.
Right. Thank you very much, Chris. Shall I move on to the recommendation? So it's recommended that members approve the submission of the Better Care Update template for 2024/25 and year-end report 2023/24 and the first quarter one report for 24/25. Is that agreed? Right, if I move on to item 7, which is Health Watch Annual Report 23/24. There's 20 minutes for this presentation. I believe you've all got copies of this report, which I think starts on page 29 in today's papers. And the presentation will be given by Kim James.
Thank you, Chair. I think I'll start by explaining what Health Watch is, so it throws some light on this, the work that we do and the report. So Health Watch is an organisation that are totally independent from health and social care. We talk to people from birth until they can't talk to us anymore. So we cover children, young people as well. And our role is to act as the voice of those people at meetings like this. So we gather their lived experience, we talk to them about the services they receive, we listen to their ideas of how things could be done better, because sometimes the people that are using those services are the best people to shape them. We write our reports regularly. We have reports, they are published out into the public domain. We use those reports to try to influence decisions around the provisions in Thurrock. We're quite a small team. We're a very small Health Watch. Some are massive, some have massive budgets. We don't. I consider us to be a poor Health Watch, but we use that quite wisely by going to where people are instead of putting on lavish meetings where people should come to us. So it has worked out well, and we have spread ourselves around the borough over the years. We are a project of Thurrock CVS, and that is purely because we are too small to be independent. Some of the Health Watches are totally independent with boards and what have you. But the good thing about that is it gives us the access to voluntary sector organisations, groups that support people who are the people we need to speak to. So it has worked really, really well all round, really, for everybody. We oversee the PALS primary care, so information, advice and signposting. So we have lots of people that come to us about issues, complaints, asking how they get registered with a GP, wanting to know where there is a dentist that could take them on, pharmacy queries, and we keep a database of who's got availability, whose lists are open, and we support those people to do that work and to get themselves registered. We work with the homeless people to make sure that they have access to services, and we listen to their stories of when they can't get access and support them to challenge that. We work quite a lot with asylum seekers and refugees. A lot of people from some of these areas will think that their only access to health is to go to the hospital because where they come from, that's what they do. So we've done lots of work about all of the options available, getting them registered with GPs, explaining the system for acute hospitals, 111 systems, and we do that regularly to make sure that those messages are received. So we set our work by listening to what's being said. So we will get individual complaints and individual issues, and they remain an individual issue. We get lots of people telling us the same thing, and when people start telling us the same thing, we start looking at what the issues are there and raise it. We have really good relationships with the people that run these services, that commission these services, and we are always able to approach somebody somewhere to try and get an answer for residents. Doesn't always work. We all know that systems at the moment are very difficult. It's very difficult for patients. It's very difficult for residents to access some services. And sometimes the calls we get are quite harrowing. But we still carry on trying to do the best we can to support those people. So in the last year, we have spoken to over 5,000 residents in Thurrock, be that at events, be that at drop-ins, being at us, going on the 100 bus, to travel around Thurrock to ask people about their services. Because on buses they're bored and on buses they'll speak, and it only costs my bus fare. And I've actually got a bus pass now, so fine. So a lot of that was around advice and information. They wanted to know where they could go, what they could do, and we supported them with that. There were an awful lot of experiences that weren't good. We had quite a lot that were good, that they had really good ideas. We write our reports. Our reports, because of the powers that Healthwatch have, we are able to make recommendations in our reports, and they have to be acted on, or they have to come back and give us a really good reason why not. We know that not everything can happen straight away. It's not Christmas morning, but we just want to know that that is now on somebody's agenda to be looked at, because we can take that back. We quite often do pledge cards with people. So that is professionals, where they say they will do something or they will look at something, and we give them a pledge card to complete. We take it away, and in 6 months' time we post it back to them and say, how are we doing? Which is a bit of a wake-up call for some people that have sort of put that on a pile to the side. So over this last year, we've had some really big issues that we've had to deal with. We were commissioned to do some work on unpaid carers, and we spoke to hundreds of people that were underneath. Nobody knew they were there. Nobody knew they were carers. These carers didn't even know they could get help. That spread out to young carers. We've done a lot of work with schools and colleges to raise their concerns that if they are the carer of a parent at home, they need access to their phone, because there might be a call from a doctor, there might be awaiting a call from home. And a lot of young people, the policies in schools are, it's a blanket, you don't use your phones. So that was looked at by education. Those young people are identified as carers, so therefore the rules should be bent, and they are now. We've had issues with parents who have children with special educational needs, who are in mainstream school with support, that when it comes to new assessments for them to move into senior schools to see whether or not that school will be able to offer that service to them, there are massive delays. That is with everything at the moment. But we also found that a few people were coming and saying they'd had the assessment but they hadn't received the report. And having looked into it and chased it around for quite some time, it seemed that the letters were being sent to wrong addresses because the health records weren't matching the school records. So there now has been put a safety net in place that before the beginning of every term, all of those children's records are checked to make sure that their addresses are still the right address. So that really was a big win for those parents. We've done some work with people who are going through gender realignment. We had lots of people telling us, well, we started off with a few around GPs not prescribing the medication they needed, the hormone medication, which was causing no end of problems for them. And we had one young man who, due to not having his medication, started his periods again and attempted suicide. There is a service up in London that all of the people in Thurrock attend. That's where they get their help, that's where they get their surgery, that's where they get their follow-ups. But what they don't get is any medication prescribed because they don't have the prescribing rights. GP's reasoning, which this isn't for me to say, was one, it was the cost, massive cost to them. And secondly, for people that had on their books who had existing long-term conditions. They weren't happy that there was any, they didn't know enough about the medication, the hormone medication, to know whether there would be any adverse effects. So as a result of all of this work and working with the ICB, there is now a service, GP service, with GPs that understand that medication, and those people go there for their medication, but their usual medication is still prescribed by their GP. So that, again, was a really good outcome for those people. We done some work with the Thurrock Stroke Project around people being discharged from hospital without knowing that there's any service available to them. That is a support service, which is peer-to-peer support. And we managed to get all of the GPs in Thurrock to send all the information out by text to any stroke survivors that they had on their books, and now have managed to now pick up lots of other people who they can now support. We have, the work we've done around the carers, we produced that report, we produced lots of videos of people telling their stories, and that report was taken to overview and scrutiny and was used to start or to form the actual new carer strategy, because it was voices throughout. And we're still doing that work around it's out to tender, the contract for carers. And with some of those people, we've been able to work with them to work on the spec, what that should look like, so it's real co-production of that piece of work. We also had picked up issues around discharge. We sit as part of the TOC, which is the Transfer of Care Hubs, which is around the discharge work. And we were commissioned to do a piece of work which took some time but was very, very in-depth. That report is now live, has been presented back to the TOC. They are aware of it. As I said earlier, we do make recommendations, but it was so difficult with this one because it was so obvious that there was nothing other than really poor communication that went throughout. Everywhere that there was a gap, there seemed to be that somebody hadn't spoken to somebody, or a document hadn't been completed, or someone had forgotten to make that phone call. So what we have asked this time is, rather than us just writing these recommendations, that we are able to facilitate some workshops, and that report will be out soon, and I know that Chair has asked us to bring that. So there are lots of other things we've done. They're all throughout the report. We work really, really hard to speak to as many people as we can and to support them in making sure their voices are heard. Thank you.
Okay, thank you, Kim. Are there any questions? Leader.
I'm not sure if it's a question or comment, really, but just thank you to Kim and Healthwatch. I think engaging with 5,000 residents over the course of the year is a significant achievement. So, you know, well done. Thank you to everybody that's taken part in that. I think for me there are a couple of things that come out. Really significant piece of work on unpaid carers, which is a theme that I think we should revisit. I still think there are a number of unpaid carers and unsupported carers who, if they weren't there, family members would be getting a much poorer quality of life, but B, it would be costing us a fortune. So I think we do need to look at how we invest properly in carers. Really interested in the discharge piece of work. Look forward to seeing that coming back. Would like to ask a question just a little bit more about the workshops you spoke about, and how many times do we kind of hear that comment that actually processes are in place, but it's the communications that are poor, that it's a breakdown in communication that leads to people not leaving hospital as early as they could do, and many other things besides. So, you know, interested in hearing just a little bit more about that, and interested to see what comes back next time. And the other one, I guess, is the piece of work that you're doing next year on dementia support. You know, there was that statistic, I don't know, last month before, 400 more births than deaths in the country last year. Dementia, the pull on our resources of growing tidal dementia is going to be incredibly significant. So, you know, I look forward to seeing the outcome of that piece of work as well. But thank you.
Thank you, Leader. Can I just ask, in terms of your discharge report, I'm going to be raising this with hospital managers in the near future. So I will also come back to the committee and to Health Watch on the conversations I actually have. Are there other things we could do to support unpaid carers, because they do so much in terms of keeping, let's be frank, costs down, and they put up with an awful lot. Are there any things that we could do better to support unpaid carers?
Thank you, Chair. I really believe that there is an awful lot out there to support people at the moment. I think the problem is that there are an awful lot of people out there that don't recognise themselves as a carer. They're just looking after a loved one. And a lot of older people in the community are very frightened to put their hand up and say that, because they fear that the person that they love and care for will be taken away from them and put in a home. So I think a lot of the messaging that needs to be out there is that there is help that we can do to help you keep that person at home and keep you both safe. As I said, we found lots of people. We found a son that had given up his job, moved out of his family home, moved down here to look after his dad, was carrying the man up and down the stairs to bed because he didn't know that there was any help available for him. And it's just such a shock. He just thought that was his duty. So I don't know how you get through that, other than we constantly speak to people. When we find people, or whatever events we're at, whatever we're talking to people about, and they sort of disclose that they're looking after somebody, we do try and get them to have an assessment. We get them to go to the carers groups round in Grays. They can help them to have an assessment. So it's all done, and they can reassure them that this is about support and help. Because what happens is these people hit crises, and then that's a massive input then. So it's just convincing an awful lot of people that they can get help.
Okay, thank you, Kim. I just want to make a brief statement myself. I would say thank you for the great work Health Watch have been doing. As a portfolio holder, as I've said to you, I'm more than open to come and meet people and talk to people, understand their real life's experience, and see what support we can actually give people who are having good and positive experiences of our health and social care.
Mr. Chair, if I could just make an additional comment. Just to let you know that there has been approval for funding for a carers intensive support service for Thurrock. It's been approved today. EPUT will start the recruitment. It will be a 2-year programme as proof of concept. It will be aimed at preventing family carers from ending up in crisis. It will be aimed at admission avoidance into hospital and into permanent care for, excuse me, for the cared for person or for the carer. There is also some work going on with primary care to identify more family carers at GP practices, and there is another stream of work that's going on to provide additional information directed at family carers around hospital discharge.
I'm really so pleased to hear that. Thank you, Margaret. Will we be receiving any information about this funding and how that's actually going to work?
Yes, as soon as I've had the discussions with EPUT, I'm happy to bring an update on that to the next Health and Wellbeing Board meeting.
Thank you very much. Can we just note that for the agenda next meeting? Thank you. Okay, so if I can move on to the recommendations, that members note the content and the report and comments upon key themes and challenges that may be identified in the report. So do we note them? Thank you. Right, if I can move on to agenda item 8, which is at the Set Lydiard. This has, I think the information is on page 53 of today's papers. There's 20 minutes for this item, 10 minutes for presentation, and 10 minutes for questions and answers. And so I'll ask Andrew Graham if he would give his presentation, please.
Thank you, Chair. Part of my role within my role as an adult commissioner is to be the Southend, Essex and Thurrock Learning from Lives of Deaf programme local area contact. And LEADER, which is how it's known, has been a programme that started since 2017. At first, it was framed around reducing health inequalities faced by people who have a learning disability, and it later expanded to autistic people. And previously to this year, so that would have been from the 1st of April 2023 to the 31st of March 2024, LEADER at the beginning of the process was an all-age 4 and up programme. In July 2023, it was decided that LEADER would become an adults-only programme nationally, and that was because there is the Child Deaf Overview Panels, which also looks at the reviews of people with a learning disability who are under the age of 18, as well as autistic people under the age of 18. And LEADER itself is a review of all aspects of care and support a person received in their life and at their death. And this is done to improve the quality of care and support by learning from what went well and making recommendations for changes where the opportunities for better outcomes come. LEADER works alongside other statutory and quality improvement measures, and it puts itself on hold if there's things such as safeguards or police inquiries or coroner's reports, so that we can capture the learning from the findings in our reviews. And it's important to flag that in this report, it provides an update on the achievements of the 3 integrated care boards across Southend, Essex and Thurrock, as well as the local authorities. We remain compliant with the revised LEADER policy in terms of team structure. That includes having a local area contact, a senior reviewer and LEADER reviewers, and we're maintaining good performance in the key performance indicators. We also share now our senior reviewer with Suffolk, and that's to help us increase learning across the wider footprint, and we already work closely with our East of England colleagues as well. And just on that slide, I've noted that we have a new 3-year LEADER deliverable plan from 2024 to 2027. That's got 12 priorities and covers 4 priorities per financial year. And the reason I reference it is because this will work alongside the recommendations made in this report. I've got some broad trends that are across Southend, Essex and Thurrock that I'll cover very quickly, and then I've got some trends for Thurrock itself. So overall, we've had 120 notifications of people, adults, with a learning disability and autistic adults, and that was notified between April 2023 and March 2024. This is an increase from the 113 deaths that were notified in the previous reporting period, which would have been 2022-23. And it's important to see it's a big increase because 7 of those in the 2022-23 period would have been for children, whereas the 120 that we've got there are all for adults. We've also seen notifications from people with a learning disability beginning to happen, and sorry, it's the previous slide. If you go back to the previous slide, sorry. On the notifications itself, we have a graph on the bottom right-hand corner that shows you that we tend to get notifications from close to where people's deaths have occurred. In previous years, you will see there's spikes in the winter, and this was the first annual report where we've seen a spike in the summer. And so we want to consider the impact of heat and hydration for people moving forwards. Next slide, please. So of the deaf reviews, the median average age of adults across Southend, Essex and Thurrock in the 2023-24 report was 59.3, and the average age in Mid and South Essex was 57. Next slide, please. For those of you who have been involved or learned of LEADER for a while, it won't be surprising that respiratory issues continue to be the leading cause of death, and within those, aspiration pneumonia. Then secondly, there is cardiac deaths, which are joint second. That's also reflected in the national report last year. But the surprising rise has been the rise in sepsis, because there had been a lot of work done in previous years to bring sepsis rates down. So it is now our joint second primary leading cause of death. For comparison, if we took a same sample size and we looked at the general population, we'd expect to see more dementia, around 12 people, followed by ischemic heart diseases and chronic lower respiratory diseases. So there's a very great difference in the leading causes of death for people in the general population compared with people with a learning disability. And you can see that in terms of the inequality in the life expectancy as well. We've continued to make respiratory health a priority in the 23-24 period, and we're continuing it into the new period, which is 2024-25. Next slide, please. So just to say on annual health checks, last year's report, we couldn't find many evidence of annual health checks having occurred for the most vulnerable people that would have been reported to leader upon their death. This year, we're seeing a lot more annual health checks, so 70% of completed reviews, we find evidence of an annual health check, but only 30% of people have an annual health check and a health action plan. And a health action plan is really important to help people stay well throughout the year until their next annual health check. And we've also seen issues around quality. It is a priority for the deliverable plan this year, so there is work being done, and there is a Mid and South Essex Learning Disability Annual Health Check Forum that's looking at some of the items regarding quality, etc. Next slide, please. So some Thurrock-specific insights. This would have been on the supplementary document that was submitted with the paper. So there were 4 reviews completed for Thurrock. 3 were initial reviews and 1 was focused. Focused means it's taken to panel and there's significant learning. The reviews consisted of 3 females and 1 male, and that's quite representative of what we saw in Leader this year. We had a disproportionate that's not representative of what we've seen overall in Leader this year, because in other parts of South and Essex and Thurrock, we saw a lot more men dying than women. The average age of death was 57, and all 4 individuals in the reviews were identified as white British. All 4 had their COVID vaccinations and had their flu vaccine, but only 2 had pneumococcal vaccine. Now, pneumococcal is a vaccine that covers sepsis, pneumonia, and meningitis, and could be a really good preventative tool. And then learning disability annual health checks, all 4 received their annual health checks and 2 received health action plans. There's been a lot of work done by Thurrock Alliance as well as the Mid and South Essex ICB regarding annual health checks in the last year, so that's not a surprise. There's been a lot of good work there. And then the DNA CPRs and the mental capacity assessments, we've seen that 4 were correctly followed for DNA CPRs and 3 were correctly followed for mental capacity acts, and that's an improvement on what we were reporting last year broadly in Leader. And but only 1 was on an end-of-life pathway. Next slide, please. So 2 people who passed away out of the 4 had the primary leading cause of death of sepsis. 1 had a cause of death of pneumonia and 1 had a cause of death of respiratory failure, and all 4 died acutely in Basildon Hospital. As you can see, we've also listed long-term conditions because there's a lot of work we want to do on long-term conditions to think about reasonable adjustments and how people access healthcare, because lots of people are managing several long-term health conditions. And in terms of psychotropic medication, 2 individuals were identified as being were being on psychotropic medication for epilepsy, but none had a serious mental health diagnosis, and 1 was on the stopover medicating people with a learning disability and autistic people on psychotropic drugs without an appropriate diagnosis pathway. Next slide, please. There are a lot of good highlights. We saw this year that 50% of the reviews that we conducted overall had good practice. A lot of the good practice that we'd seen came from the learning disability liaison nurses and healthcare assistants. They also cover autism as well, it's important to say. There was the first aspiration pneumonia conference of its kind in the east of England, led by Essex County Council's Provider Quality and Innovation team, but it was open to the whole of Southend, Essex and Thurrock, and I've had feedback from at least 1 Thurrock provider that they found it really useful, and it's something that they're going to take forward into their care. There's also been a Mid and South Essex NHS Foundation Trust matrix for leader learning established, and there's been a lot of good work done regarding ageing well, and then also work on end of life. Previously last year I reported on some updates of the good work that happened across Thurrock Council's adult social care, working with GPs and also the work of public health, but this is in addition, so that's why we've highlighted this in this year's report. Next slide, please. So we've got 14 recommendations. Each recommendation is attached to the theme. So the awareness is to promote awareness to autistic people, because we're not getting enough autistic people's reviews. We need to learn what health inequalities they face. And also we want to understand more of how ethnic minority groups experience care, because broadly across South End, Essex and Thurrock, we're getting white British reviews to the equivalent of the 2021 census, but we need a bigger sample size to learn the nuances of the health inequalities that ethnic minorities face. Reasonable adjustments is a conduit to healthcare. It's really important to help people get healthcare throughout their year, and there's a lot of work nationally being done on a reasonable adjustment digital flag. And then the targeted work on aspiration pneumonia and postural support, and then raising awareness of pneumococcal, which is number 5, and number 6, dentistry. They all cover the respiratory work. Dentistry and postural support really are 2 of the risk factors of aspiration pneumonia, which is our leading killer. And in that side there, I've recommended that wherever possible, that people with a learning disability and autistic people are prioritised, because their oral health is really important to that risk factor. Plans for ageing and end of life. You saw from the Thurrock slide that all 4 died in hospital. We want to empower people to make choices about where they pass away wherever possible. So ageing well and end of life plans are really, really important. We've put here bereavement support for families who lost their loved ones in community, because we had some feedback in reviews that there wasn't always the same level of support for people whose loved one passed away in a community versus in acute setting or a hospice. And then we've kept mental capacity assessments and DNA CPRs on there. Although we're seeing a lot of good practice, we still want to make sure that that's continued, because we do see the odd example of where the process wasn't correctly followed. Next slide, please. So we've got some work to continue to analyse and raise awareness of the most common genetic and long-term conditions, as well as sepsis, because we think managing conditions will be really important to help people stay well as they age. Sepsis is really important because we've seen the spike this year, and along with the pneumococcal vaccine, that could be a really big preventative tool. And then we also want to increase the representation on our quality panels that we have. We have one for Mid and South Essex, and we also have the leader steering group. So we'd love for more representation from organisations on there to help us push this work forward. And then the significant risk training to be explored for health and social care to help people stay well in winter and the summer. The national report reported on a spike in deaths in the summer. We saw it in this year's leader annual report, and we want to make sure that the deterioration that people may experience in hot weather, not hydrating enough, etc., can be at least looked at, because we want to make sure that we don't see this repeated in future years. All of these recommendations are followed by an action plan that's in the report, and they've been allocated to different organisations. This went through the leader steering group, as well as the Learning Disability and Autism Health Equality Board, and they're all actions to support a specific recommendation. Final slide, please. So this is the first Health and Wellbeing Board that this report is going to. It will also be going to the Essex Health and Wellbeing Board and South End. Once it's completed that board, it will be considered published, and we will also be publishing an easy read version. And we also would ask that people promote the learning and recommendations from the annual report. And it's just to note, this annual report is written before the 2023 England Leader Annual Report. Last year's report for 2022 was published on the 30th of November 2023, so we expect it at some point in the autumn, but it's just to flag that we will be looking at that, and we will be doing a piece of work to understand if there's any contrast between our report and the national report. And then if anyone would like to get involved with Leader or has any questions, then I've put the Leader email address, which is essex.leader@essex.gov.uk. Thank you.
Okay, thank you. Thank you, Andrew. Are there any questions? Rita.
Thank you. A few comments. First of all, really good to see the work that's been done and the recognition of health professionals in this field. I am concerned there's not enough of them for our localities. We have done some work. We're following a workshop over at the Beehive that we've linked our health professionals, and there's only a few. to our integrated locality teams to support that awareness and link up around the annual plans and the annual checks, etc. as well. Secondly, in terms of aspiration pneumonia, so aspiration pneumonia is when food and fluid goes down into the lungs. And I'm saying this as a speech and language therapist by background, so it's really important to me and really passionate about this area. And we've really got to get this right. And often eating and drinking is an area of absolute comfort and choice. And it's quite complex when working with someone with learning disabilities as well. So again, that awareness training is key, and an understanding of choice and how we support people making these choices is really important. But awareness across our communities and those locality teams again. So I really do recognise this report, and I think there's a lot more we need to do in this field, and particularly in our integrated locality teams of each of our areas where we can really build that awareness and that primary factor around choice and eating and drinking and making sure we get it right for individuals.
Do you want to respond to that?
Oh, it was just to say to recognise the speech and language therapists are some of the most positive feedback that we get about, because it is really, really important. I understand what you're saying in terms of capacity, etc., but I think there is a real willingness in the system to push this work forward, and there is a lot of green shoots, and I think that's why we've asked for more representation, because we kind of want more wheels to push a lot of the recommendations forward, because things like aspiration pneumonia, I would like to see not as one of our leading causes of death. I would like to see that things change. In the national report, cancer is far higher. We don't see cancer high at all. So there are lots of things, but east of England, aspiration pneumonia is high. So there's a lot of work we want to do in terms of respiratory. And aspiration pneumonia, the risk factors, you can, as you rightly said, you can like minimise a lot of those risk factors. So it is really important. And we do hope that things will change moving forward, especially given the work that's going on across the system.
Councillor Kent.
Can I just follow that one up a little? So really pleased to see a focus on access to dentistry for the same reason. But we know that speech and language services in this area are nowhere near where they should be. So I guess my question is, what can we as a board do to try and get the accelerators behind getting improvement in that field? And the second one is just the fundamental that we're saying that people with learning difficulties, autism, are likely to die before they reach 60, and you know that's just shocking. And when you look at it, annual health checks, which when I was on this board when it was first formed 10 years ago, annual health checks just weren't being carried out, and we're still only at 70%. And from that 70%, only 30% have a health action plan put in place. And you know, that's just not good enough. So what can we do to make a difference and get those checks and get those action plans to where they need to be?
Thank you, Councillor. So in terms of the work with speech and language therapists, at the Aspiration Pneumonia Conference, there was a lot of focus on upskilling care staff to show them how you can thicken food and make it safe for people who have the dietary requirements. There's a lot of work that could be done there. In terms of the age gap, I'm equally shocked, obviously, the difference in age between the general population and people with a learning disability. We do see the annual health check as the North Star, and that's why I think there's always a question around quality. Health action plans are really important because they help guide people forward, and I think there's a lot of work being done now, because I think traditionally health action plans were given, but rather informally, rather than this is like, you need to eat less, move more, there's a few things you need to do to access healthcare, whereas actually providing people with a roadmap. And the good thing about an annual health check is it's not just something for the individual, but the people who care for them, social care and as well as health, can all understand what one's needs are. They're also an opportunity to look at weight. So we would always say that annual health checks, although they're not where they are, where we would want to be from the people who are reported to leader, I think there is a lot of good work going on that we will hope to see more people living longer and having better access to healthcare through annual health checks as that North Star in their year.
So I accept the point about quality of health action plans. It needs to be good quality. But what we're still accepting is that fewer than 1 in 3 of these people from this cohort are receiving those action plans. So what is it that we're going to do to make a difference and get that from fewer than 1 in 3 to I don't know, 9 in 10?
Thank you, Councillor. So in the deliverable plan this year, annual health checks are a priority. We have the Mid and South Essex Learning Disability Annual Health Check Forum. Part of that is in the previous annual report we said that every single annual health check should have a health action plan. This is the wider numbers, not just the people from LEADER. And we are seeing that health action plans are growing in comparison to the number of annual health checks. They're not one-to-one, but we are seeing that growth. We're also through that group looking at quality and looking to get feedback from the public as well and what their experiences are, because we're often told, you know, different varying experiences. There's some really good experiences, and there's some experiences where people feel that they could have more time to discuss things that they want to discuss. So there's a broader piece of work working on that. Leaders always for the people who have unfortunately passed away. So we would expect in next year's annual report to see an improvement on that to reflect the work that's been done over the last year.
Okay, thank you. I've got a number of questions, Andrew, I'm sorry. In terms of where the health action plans are or are not, are they more likely to be in the family situation, in a residential situation, or supported living service point of view?
So each individual that gets a health action plan, if they're in care provision or supported living, we would hope that they would be sharing that with the care and support so they can help implement some of those changes to help them keep well. If they have an informal carer, the informal carers, we have feedback, use that to understand some of the things that they need to do to help improve their health. The health action plan is basically your next steps for the following year on ways to stay healthy. Sometimes that's to improve your health, sometimes it's to maintain your health or prevent against deterioration. And there is each avenue that you work with should have sight of your health action plan. Social care reviews, for instance, is a really good point for people, social care, to ask about health action plans so they can help have knowledge of it in the care that they give from a social care perspective. So it is owned by the individual, but its use can be universal to the people who support them.
So do GPs know they should be helping families and services with the health action plans?
Yeah, so the health action plans are set out, and the GP will sign it off, but the GP will be part of the group who signs it off. It's not always a GP who writes the annual health check and the health action plan, but they do have sight of them.
So I'm going back to what Councillor Kemp was basically saying. What's the plan to really try and improve the number of health action plans, because they can help prevent a lot of deaths or illnesses. A lot of things around aspiration and feeding properly would form part of that action plan. Medication reviews. I mean, I see that you presented a report with people maybe not being on medication they should be on. So I think having the health action plans are quite important. So how can we get from that kind of 30% up to 90+%?
I think part of the way to do that is there's raising awareness with the GP staff about the importance of health action plans, and also formalising to let families and people know what a health action plan is, because quite often it was given informally. But the other part is reasonable adjustments. We still see a number of people who decline annual health checks every year, and I think that there's a lot of work to be done with the most vulnerable people and also young people, because annual health checks are from 14 up, to raise awareness of annual health checks. We hear too often people don't know about annual health checks till they're in their mid-20s. So there's some work that we're looking to do for the 14 to 17 cohort to start that process of having annual health checks and health action plans. In terms of the health action plan work, there's a lot of work going on, I know, with Alliance colleagues and with the ICB to raise awareness of having an annual health check earlier in the year, because they're traditionally done at the end of the year, and we think that combined with the push for health action plans will push the number of health action plans that come up because you're right, all of the things that you said could be covered by a health action plan of, referral to SALT services if you've got risk of aspiration pneumonia, etc. So there's a lot of work going on, but there isn't a kind of one straight line to get there. There's a lot of work going on to try and push that work forward.
Okay, so what would your action plan for Thurrock be?
Thurrock in the last year has really increased the number of annual health checks and health action plans. It would be good that we've done it in a different area, but to get the primary care networks to provide an example of an annual health check and health action plan that they've done redacted, and then people can kind of look at that and comment on what's working well there and what are some of the things that needs to move forward. That potentially could be done at a time to learn or something like that. But that's why we have these forums, like the annual health check forum, where Thurrock is represented, and what we've been discussing about in terms of quality. And we're going to be taking the redacted examples from other areas to that to discuss what a good annual health check looks like. So that would kind of be where I would think we could get a lot of green shoots, because I think you don't know what one looks like or what a good one looks like until you start looking at ones that exist.
Okay, and are services like local authority services, as part of their contract monitoring, I don't know, monitor the quality of health action plans?
It would depend on the spec that they have, Chair.
Okay, I think that's one I'll take away. Okay, are there any other questions? Well, thank you, Andrew. If I could just move on to, it's recommended that members note the Lydiard Annual Reports 23-24 and associated documents. The set Lydia 3-year deliverable plan for 24-27. Is that noted? Noted. Okay. I take great interest in this. I may follow up with you, Andrew, as someone who spent 39 years in working in learning disability services. And I'm actually really quite surprised how poor the figures are compared to maybe other areas like London, for example. So I'll be quite keen to maybe follow up with you at some point. Right, if I can move to agenda item 9, which is connected pathways. I think you'll find the information on page 179 in today's papers. There's 20 minutes for this item, 10 minutes of a presentation and 10 minutes of questions. And I'd like to invite Margaret Allen to... Is Alison here? No, she's not here, is she?
Yeah, I am.
Oh, yes, you are? Oh, of course you are. I do apologise.
I did smile watching Margaret's face drop then.
Okay. We'll be presenting this item. So, over to you guys.
Thank you. And thanks for inviting us here today to look at the work of my team. I was going to go through the national context for the Primary Care Access Recovery Programme, what our local solution is in Mid and South Essex. Part of the Primary Care Access Recovery is the Connected Pathways team, which I lead, and then obviously allow questions, time for Qs and As. So if you can move on a couple of slides, please. Thank you. In last May, NHS England published the first delivery plan for primary care access recovery. As you are all, we are all patients at GP surgeries, and we have all hung on the phone or queued up at 8 o'clock in the morning when you're feeling really poorly, wanting to see a GP. And that document tries to tackle that by moving away from that 8 a.m. rush and reducing the number of people that are struggling to contact their practice, predominantly over the telephone. And then when you undoubtedly do get through eventually, you have, you're told there's no more appointments, we're going to call back the next day. And it's a recurring cycle. So what we are trying to do is implement they call it the Modern General Practice Access Model. I've put, you can see the diagram there. And what that looks to do is, for the telephony, we've been involved in replacing lots of GP practices' phone systems. We got money from NHS England to achieve that. The old analogue lines, there weren't enough lines going into the GP surgeries, and BT nationally are also stopping the copper wire. So all the GP practices require a cloud-based telephony system. It's good for business continuity. If something happens at the surgery, then those phone lines can be picked up from another building because it's all cloud-based. And what the Modern General Practice Access tries to do is to provide parity between patients who choose to phone their GP practice, patients who choose to contact them online, and patients who choose to walk in. And the idea is that if you're phoning or walking in, your receptionist will take the details down of why you want that appointment. That then gets triaged. That then gets triaged either by reception. This is what they do. If you've got a bad back, they'll send you to the physio. If you've got, a minor illness, they'll put you in with your advanced nurse practitioner. But it's actually capturing all of that demand on primary care, because hospitals have been really, really good at providing data. But general practice, because they are such small individual little businesses, actually capturing the demand placed on primary care has been historically very, very difficult. So trying to encourage people who are digitally enabled to contact their practice online, therefore reduces the traffic that goes towards the telephone system. The new phone systems also have a callback function. So if you do choose to phone up and you are, 80 in the queue and you don't want to sit and wait there, you can press whatever button, number button they want you to, and the system will phone you back when you're next in line to work with the receptionist. So that is kind of modern general practice access. It looks at working with, the fuller stock take findings about developing those integrated neighbourhood teams and making sure that the ICBs are creating an environment for change so we can support our GP practices to make what is essentially quite a large business change. Next slide, please. Oh, sorry, can you go back one? So the Mid and South Essex target operating model for out-of-hospital services is looking at the three core functions of urgent and episodic care, complex care and prevention. And primary care is exactly the same. You have your planned care where you have your annual reviews, your IMS and VACs, your vitamin B12 injections, and then your urgent on-the-day demand. So, enabling practices to identify and stratify those two types of demand and using a wider group of people to see those patients, who are more appropriate for their needs. We are very, very hopeful that that's going to make a huge difference. The practices that have already gone down this model have reported to us that they would never ever go back to the old system of the 8 a.m. rush. So to be able to, I briefly touched on with that graphic, this total triage approach moves away from the phones and that first come, first served approach, and using the system to make the digital tools those alternative care pathways and increasing capacity and using the integrated neighbourhood teams as required. So there's that differentiated demand and how the integrated neighbourhood teams and the transfer of care hubs can help. Obviously, these are in development. Nothing's going to happen immediately, and with any type of cultural change and systemic change, it takes time. People are very, very, clinicians can be very, very set in their ways. Next slide, please. So that's just kind of the governance for the Primary Care Access Recovery Programme in Mid and South Essex. So my team looks at total triage and digital tools, care navigation training, kind of the website development and digital. We have optimisation of the workforce. So we have a primary care workforce team that have supported all our networks to expand their R's roles. We have the improving the primary care, secondary care interface, the bureaucracy that is generated between primary care, community care and secondary care is large. We want to improve the safety and the quality and the efficiency for clinical and admin staff because of the volume of paperwork that is produced. And then obviously the integrated neighbourhood teams. So we've got our alliance directors leading on those. So next slide, please. So for my team, the objectives were to recruit the team. I came into post on the 1st of January. We had a full team by May. There's only 5 of us. But the idea is that we'll support practices to implement the modern general practice access model, including the cloud-based telephony rollout. There is a huge comms programme planned for stakeholders and the public regarding modern general practice access. And we need to have supplied additional digital tools as well as increasing the use of the NHS app. Part of the document required ICBs to have at least 10 self-referral pathways by the end of March 24, and we actually had 12 in Mid and South Essex. We also were given the objective of improving the patient experience of primary care and improving the staff experience of primary care. So I'm really, really happy to see Kim here and look forward to working very closely with her again on that. So we put an offer out to practices and PCNs around the self-referral pathways, around having a dedicated website as part of the ICB's website that's got lots of resources for practices and other primary care contractors on how they can implement modern general practice, how others have found it, and take the learning from elsewhere. With regards to the digital tools, we have analysed and continue to analyse the NHS app use and target practices that have low use. We want to do this via PPGs because we've found that they've been really helpful if you've got people, that are willing to sit in the waiting room and talk to their, the patients of the surgery and show them what the app does, how to use all the digital tools. That can be really, really effective. Working with practices who do not enable planned care appointments. So this piece of work is just about to start. As I said, you've got planned and unplanned care in primary care, just as you have in, thank you, emergency care. I'm just going to flick to the next slide and then you can see the progress that we've made. So we have just purchased a digital tool called AccuRx. What the practices can now do with that is for all of their planned care appointments, they can send a text message out to the relevant patients with the clinic link that they can book in, because one of the big issues that practices were having with online booking was people would always book into the GP when they didn't necessarily need it. The patient experience, we've got some work commencing in this autumn to work really closely with PPGs. We're working with practices to submit their friends and family test, supporting them with data, and then a big comms planned for winter. And just to update, the slide that you have said that 24 practices had been approved for transition funding to move over to that general practice model. That's gone up to 29 now. Everything moves on an almost daily basis. So I'll stop there because you can all read. Happy to take any questions.
Okay, any questions? My only concern with some of the digital stuff in particular is our older people, learning disabilities, people with mental health and autism being able to access this or understand how to use it. The last report I saw around Thurrock, around about 20% of people were IT illiterate.
Yeah.
So what safeguards have we got in place to ensure that people can still access a kind of triage service?
So it is for people who choose to telephone or walk in, they won't see any difference. So it's about encouraging people who are digitally enabled to use that route, which then frees up the phones for the people that aren't digitally enabled. So if you wanted to walk into your GP practice to ask for an appointment, you essentially won't see anything different. The receptionist will be behind the counter. She'll be typing, asking you the questions, what the problem is, what would you like to happen, and then dishing out those appropriate appointments as required.
Okay, the other thing that I found is that what is traditionally known as receptionist tends to be the care coordinator. Is that right?
Yes.
So sometimes someone will call and actually say, well, I'm not telling you, I want to tell my doctor, because we've created that culture, we speak to our doctor. So what comms are we doing around sort of like telling people the role of the care coordinator rather than the receptionist?
So there has been quite a lot of comms about that in the past. It's definitely part of our comms campaign. We know that this is not only a cultural shift for our clinicians, but also the general public. We've got lots of people out there that go, I want to see my GP. But, your GP may not be the most appropriate clinician for your needs. So getting them to accept that care navigators will ask a brief discussion. As part of the comms work that we're doing, we are providing, again, it's for digital, but on the practices websites, there will be an explanation that your care navigator will ask you the reason why, and it will be the same questions that you'll have on the online tool. So there is that parity between people's choice of how they contact primary care.
Are we putting anything out on normally you get a handbook when you join a practice, or
Yes,
on GPs' websites about the change of practice?
Yeah, all the comms that we will be producing will be up to the practice to copy and put on their relevant comms, and obviously promotion out to the PPGs as well. Posters in waiting rooms, all the normal print stuff.
Okay, thank you. Any other questions? No? Okay, then, that being the case, thank you. Thank you, Alison. I'll move to the recommendations that members note basically the progress or have commented on the pathway programme. So I think we've commented. So thank you very much. With that, I will call the meeting to a close. Thank you very much.